First off, I want to thank the brave men and women who work behind the wall. I want to thank them on a national level because their job goes unrecognized.
How do they try to turn a guard?
Well, correctional officer. Sorry, I apologize. But correctional officer.
How you guys doing today? It's Anthony Gangi, host of Tier Talk. Welcome back to another episode of Tier Talk. By the way, guys, 7,000 subs. I think that's a great milestone. So thank you guys for your continued support. And the topics we do right now are topics that you're interested in, which helps me build my viewership. Now, today's going to be a very interesting show. We're going to be talking about medication-assisted treatment. Believe it or not, it was a crazy response I got when I suggested the idea that we were going to cover this on my channel. I was out at Seton Hall, I believe, and I just did a quick blurb, and I started getting these emails that actually had some very good specific questions, very balanced questions, because I found that some of the questions came from custody professionals, and some of the questions came from medical. So there's definitely a look to partner those concerns, and I think that's why it's very important that I have these two guests on my show. One is a regular right now. She's been coming back and forth, and I know she's very busy. She had a very busy weekend, but she was able to manage to find some time for me today, and that's Connie Alleyne, who is the CEO of the Civilian Corrections Academy. Connie, how are you?
I'm good, thank you. I'm good. Very excited.
You are the target of my interview today, so get ready, because I don't know if you're going to be smiling much longer, because we're going to hit you with some questions.
It's all good.
All right, just want to make sure. And then obviously my security expert right down below, Russ Hamilton, retired sergeant out of San Quentin. What's up, Russ?
Hey, how's it going, Anthony?
Milestone for Russ Hamilton as well. Broke over 1,000-something followers in a group that he founded called Keepers of Chaos. That's K-A-O-S. And he did that on purpose, guys. Don't correct him. Because a lot of people think that, hey, he's spelling chaos wrong. Guys, he knows he did that on purpose. And you can find that group on Facebook. And I'm going to tell you something, guys. The information that's starting to come up on that group, great information. I'm learning a lot. And I feel that group, even though it's 1,000, I know it's growing, it's more family-oriented. I really find that people are trying to get involved and help each other, just discussing multiple topics. Not always corrections either, which is pretty good. I like that. So when we get back from our sponsor, we're going to go ahead and start our discussion on medication-assisted treatment. I got a list of some questions that were given to me by some of my viewership, and I really do think that this is going to be a very good dialogue. Hopefully this touches into some future discussions, because we already talked about something that we may not be able to get to today, but we're definitely going to consider it in a future discussion. So stand by for our sponsors. And guys, if you haven't, the show Tier Talks for you, brave men and women that work in corrections. So please subscribe, interact, engage, comment, hit that bell. That bell's going to notify you every time I post a video. All right, guys, stand by.
I wanted to attend a university that had an intelligence program. I wanted to look at problems different. I wanted to increase my critical thinking abilities. AMU offered those avenues to expand. Obtaining your degree as an adult, you're actually paying yourself and investing in yourself. You can't put a dollar on it. It's priceless. It's something that can never be taken away from you.
American Military University. Learn from the leader.
All right, guys, we're back. So the conversation is going to be medication-assisted treatment. I know a lot of facilities are going through that right now, and I know there's a big conflict between what's being requested for medical and safety and security concerns. So right off the bat, my first question is going to go right to Connie. Connie. For some, you know what? I work with a Colleen. So I just want to let you guys know that. So sometimes I kind of throw out the wrong name, but obviously I know who you are, and a lot of people in this field know who you are. You're very recognized for the hard work and dedication that you put in making sure that our civilians are trained. And again, let me thank you for that. And that's kind of my, kind of like you're okay with me because I said the wrong name, so thank you. So explain to me, Connie, what is medication-assisted treatment?
All right, so I think really this conversation should start from the top, because I think people oftentimes feel that medical is coming from this soft and fluffy place and that we're just all bleeding hearts. But I think most people don't realize that, healthcare is a constitutional right. It is the 8th Amendment that has inmates with the right to health care, and really the prohibition of any cruel and unusual punishment. So part of this MAT is that when the body goes through a detox or a withdrawal, there is a significant amount of negative symptoms that the body will go through. So the purpose of MAT is really to have this medically managed process of detoxing. so that you don't have the tremors, you don't have the chills, you don't have excessive vomiting, you don't have all of those side effects that come from going through a withdrawal when you do the cold turkey kind of way of doing things. And I think what we really need to think about too is that with the whole opioid addiction, like, it is an epidemic, right? There's no way that we can get around that. And that's in the United States in general. I mean, the fact that we're at a point where I think the CDC says there's about 91 Americans die each day of opioid overdose. And so what we see in the prison is you have these inmates who are chemically addicted, multiple meds that they're addicted to. And when they go through their withdrawal or their detox, it's really significant. It's not like how normal detox you see, they have like signs and symptoms that mimic like the flu, right? But there are two distinct phases of withdrawal that you'll see, like early withdrawal where they get sort of the muscle aches, the teary eyes, runny noses, yawning, like insomnia, agitation, anxiety, sweating. I mean, and just that's probably for many people what they feel just being in prison, right? But then you have the late withdrawal where you start having the nausea, the vomiting, the chills, the goosebumps, the diarrhea, the abdominal cramps, the dilated pupils. And those are the things that, you know, when you think of MAT has a way of sort of halting those symptoms or suppressing those symptoms. And that's why it's such a big deal to have MAT in the facilities. Now, MAT isn't just having the medication, it's also the combination of medication and like behavioral therapy or like psychotherapy. So if you're actually getting or you've been inducted into the MAT program in a facility, you have to actually go through the mental health side of things. You have to go through the behavioral side of treatment so that they actually teach you how to live life without being addicted. And how do you change your behaviors? That's like a whole other process. But for MAT, there are multiple meds that you could be taking. Right now, it is that buprenorphine and methadone are supposedly like the gold standard for MAT. But then you have Suboxone, you have Subutex, and you have Vivitrol. And what they all have in common is they all treat addiction, they all suppress symptoms of withdrawal, and they all decrease like the cravings for the opioids. They sort of block the body wanting to have the opioids in the body. But they don't produce the high, which is what most people think, that, you know, you're giving them a way to get high. The actual, if they're taking the medication as prescribed, they won't feel the high that we think they're going to be feeling. It actually just suppresses their desire to continue using. So it really helps them to stay on course with treatment.
Well, wait, you mentioned something very important there, and that's where I think my custody can relate to that topic. If they're taking the medication as prescribed. So if they take more than they're supposed to, can it give them a high?
So it does have the ability to do that because it is a synthetic opioid. But the thing with it is that, so whoever the prescribers are, there's so many, I think, points where you should be having a sort of checks and balances that happens. So for example, if inmate is supposed to get this one dose every day, same time, and the inmate doesn't show up, then the translation is the inmate must not need it. And so there's the nurse who's administering should be going back to the prescriber, whoever the psychiatrist is or the medical person is, and saying, you know, John Doe hasn't showed up for his meds the last 3 days. Clearly he doesn't need it, but then he just pops back up on the radar to get it. So what that prescriber is supposed to do is meet with the inmate to find out why they're not coming for the meds. And if in fact they don't need it, they're supposed to remove that prescription from the inmate's med pack. But you have that inmate who comes down same time every day. People generally know who's coming for maintenance. right? Simply because it should be the same time every day, and there shouldn't be other inmates in transit while that med pass is happening, because that does open the door for meds to get passed on to someone else who shouldn't be getting it.
Right now, going back real quick, because I do want to explore the symptoms, the withdrawal. Now, if we lived in a perfect world and we didn't have the fear of inmates being able to misuse the MATs, I would be okay with them taking it, only because I don't want to be around diarrhea and vomit. I mean, would you agree with that, Russ? If we lived in a perfect world and there was no fear that the inmates could misuse the MATs, having them take the MATs and not going through the withdrawal does protect us a little bit, correct?
I think, yeah, I think that any time something that makes our job a little more pleasant or a little less unpleasant, it can always be a positive thing. You know, as far as you know, just having those things there for you know, for their comfort, or you know, to apply to their own discomfort. You know, it is what it is. That's where we're at with the way the process is, and so we just have to find a way to fill in the gap that we fill in and serve the part of that we serve, being on the, you know, safety, security, and custody side of the equation.
And that's why it's great to have a dialogue like this, because actually there's a couple other things that you brought up just now, Connie, that I felt I never thought of before, actually, and it's talking about the weaning off. So now I'm thinking withdrawals are automatic symptoms. I mean, after a while, you're off a drug, you're going to know, okay, I'm going to kick, I'm going to be, you know, I'm going to be withdrawing. But eventually, I'm assuming that, you know, once you take these MATs, eventually the symptoms start to stop. So when you have a guy that hasn't been at the med line for 3 days, and that was a great example, why would we want to put him back on?
Well, I think what it is too is that understanding with addiction, like, so you have, addiction is typically chronic, and there is this relapsing that happens in the brain that affects them psychologically and physically. And so just because, you know, someone may not be taking the med for a couple of days, it generally takes quite a few days for the med to wear off in the body, right? So even though 2 or 3 days has passed, they may still be kind of getting by, and by day 3, like, they're starting to feel the crave, or they're starting to see the signs and symptoms of actual withdrawal, so they come back online. So I think it depends. And like the drug withdrawal symptoms, they vary. So like if it's like heroin and like prescription pills, you know, you might have those flu-like symptoms, but then that can last an average of 5 days. But then if you have like cocaine, you'll see some depression and like restlessness, and that kind of lasts for like 7 to 10 days. But then you see alcohol, and that withdrawal, like you see the tremors, and they can go into seizures, and that can last anywhere from 3 days to several weeks. So it really depends on what meds they were addicted to and really how long they've been addicted for. And a lot of what the research shows is that with MAT, when they are actually following like the treatment regimen the way they should be, like, these are the people who, if they stop taking it and get back on, they're more likely to overdose. Like if they stop taking it and then they get released, because their body is accustomed now to this suppressed state of craving. When they go back out and try to go get their next hit, they are usually the ones who are going to overdose, because they don't realize that what they used to take, or whatever drugs, whatever amount they used to take, right, that would get them high previously, they no longer need that much in order to get high, because they've been suppressed for so long.
Now, that's actually a great point too, because I know that's one of the concerns. They go back to their latest dose, and unfortunately the dose is too high. Their body's tolerance has lessened, I guess. Let me ask you a question, because I'm trying to get to a discussion where we kind of don't. I'm trying to limit the misuse of the medication, you know. And one of the concerns we have, I know from a custody level, is how long they have to be on it. So I know you mentioned days, weeks, But is there ever a point where we can safely say, hey, this person doesn't need it anymore and it's time to start getting them off it?
Absolutely. I mean, so there's always that jail versus prison discussion, right? If they come into jail, they're not sentenced yet, you know, they've been being maintained in the community, and then they come in. For us to stop abruptly would be, you know, bad for their body, bad for everything, right? They could have been stable previously, and now we've offset the apple cart essentially. When they come into, but then I think the other discussion that I've seen points brought up about is like, so someone might be in on the jail side of things, but they haven't been sentenced yet, but they're facing a felony. Does it make sense to maintain them knowing that they're probably not going to get out anytime soon, right? They're going to fight this case for however long they're going to fight it for. And most likely if they're sentenced, they're going to be down for a long term. So typically the MAT, like, so with methadone, they do like 20 milligrams and then they start to taper off, where people are medically still being managed, but over a period of time, they should be able to come off of the medication. Now, different prescribers have different practices, and the standard of care changes, or it may vary from state to state. So I think it really matters that the prescriber is aware of whatever the most recent standard of care is, so that they know what's the safe tapering amount, and, you know, how to get them remain stable during the time that they're in. When they're sentenced, that's just another discussion, because there is this thought process that, you know, if you maintain them on methadone and they're stable while they're in the facilities, that they're less likely to be one of the inmates that'll give you any behavioral issues. They won't get as many disciplines as someone else who hasn't been stabilized. I don't know how true that is. I mean, there's some research that's out there that supports it, but I mean, you always got to think, what was the population size? Like, what did they come up with the numbers, right? What was the population size? You know, was the study biased? Exactly. So depending on which way that person was trying to sway the discussion, who knows what the numbers actually represented. I haven't seen it to know and be able to say this is it for a fact. But, you know, it's also that argument that if someone is diabetic and they come in, we don't take away their insulin. If someone is an asthmatic, we don't take away their inhaler. So here it is, someone else who comes in with another disease. Why would we want to take it away?
No, and you know what? I respect that. And before I move on to policy and procedure, where I want to have custody, I definitely want to start involving Russ in it. I want to mention one last thing, something again that you touched on. Is there a target for most? So basically, if I'm planning on starting this patient on Suboxone, is there an end? Like, I mean, is that in sight at the very beginning?
So it depends on whatever that patient is presenting with. So if the patient has a very long history of drug abuse, and it may take longer for you to even consider a taper, you know, and I think the other thing too is that with some of these meds, they actually are pain relievers. And most of these men and women come in with all these other comorbidities that they're just uncomfortable in their state of being. And if they've been stabilized on a particular medication regimen in the community, they usually try to maintain that medication regimen in the facility. Like, there's a lot of efforts that they go through to get the medication, whatever treatment they were getting, to get those records from the community so that they're aligned with whatever treatment that has them stable. So it depends on the inmate.
Okay, but at least we know. I basically want the audience to know that they're not being given an infinite supply, that there is a try for medical to eventually take them off that MAT. I just feel that a lot of us feel that it's given and it's infinite. You know, we're not going to stop, and I want them to know that medical does try to bring it to an end. I mean, that's pretty much the process. And also, what are the signs really quick of misuse? How do we know if someone's misusing it?
Well, if you see someone who just doesn't show up, that's like a big sign. And I think when you see someone starting to exhibit signs of or symptoms of withdrawal, because that's not supposed to happen if they're actually taking the medication as prescribed. So if you see someone who seems really sick, you know, they've got those flu-like symptoms, they've got the muscle aches, they got the runny nose, they got the insomnia or the agitation or the anxiety, like all of those are signs and symptoms of someone who's withdrawing. So the one way you could really tell is that all of a sudden this person's been pretty stable, but now they're showing signs that they're withdrawing.
Right. And then when you said someone doesn't show up, obviously you're expecting them to show up because they should be going through withdrawal concerns, correct? So when they don't show up, is there an immediate follow-up from medical to find out why they didn't show up?
So yes. So typically, you know, once Medline is called specifically for MAT, those inmates usually are lined up. And it's often a concern if someone just doesn't show up, if they're not in school, if they're not at, you know, a legal visit or something that would really keep them away from Medline. There's usually a concern because prescribing practice, or the expectation is that you get those meds the same time every day. And so in order for you to maintain, to be stable during that time, it is getting those meds the same time every day. Guy doesn't show up, or woman doesn't show up, nurses automatically calling the housing unit to find out, like, you know, what's going on. Is he coming, not coming, or what's the issue? Because it could be that the person is going through some withdrawal in a cell, and we just don't know what's happening in the cell. But immediately we're calling to figure out, like, how come they didn't come down to get it? And if that's the case, they're usually then placed on the next follow-up sheet for the psychiatrist or for a medical to actually see that patient and assess whether or not they're still, you know, appropriate for MAT.
So definitely that communication between medical and custody is paramount.
Absolutely.
And that's something we always try to encourage here. So now this is where we're going to kind of get Russ a little more involved. But again, I'm going to kick to Connie one more question first. And we're going to be talking about policy and procedure. So from your experience, I don't know, you mentioned the different medications. Well, let's start this way, actually. What are some of the medications that would be considered MATs?
So the buprenorphine, methadone, Suboxone, there's Subutex, and there's Vivitrol. Okay. So with those five, I think there's like 5 or 6 of them, with those essentially do pretty much the same thing. There is some variation about how much blocking effects it has. Like some will block the craving for the actual opioid. Others will have like a different impact, like it blocks the brain from wanting some things. Like, so I'm not into the science of it all to be able to explain it in detail, but for the most part, this one may suppress, this one also provides pain, like pain management, or like helps you to manage your pain. So it's a painkiller. Others do not have that property of reducing pain, which is usually associated with going through withdrawal.
So what would be the different ways that inmates can take that medication? That's where I think it will be good for Russ to start interjecting a little bit too, but I want to go to you first. What are some of the ways they can take, let's say, Suboxone, Vivitrol? How are they being delivered to the inmates, and how do the inmates take it?
So there are some that they have to sit with the medication under their tongue. There's some that you can have it sit in like a cup of water, and then they drink it, so they don't get the pill form of it. It's already dissolved. And typically what you make them do is after they've taken it, they drink a few cups of water after to make sure that the pill is gone down, or if there's like the strip has now dissolved. So it's different. And so you've got like the sublingual, you've got the tablet form. They also have like the transdermal patch, but I don't think we brought the patches into the facilities. And they also have injections. Mm-hmm. Now, injections would be the ideal way for you because then there's no way they can give it to anybody. However, I think the injection is a little more expensive. So from a fiscal perspective, it's probably not feasible. And so we've gone the sublingual and the tablet form.
Speaking of expense, what is the cheapest out of all the 5? Would you know? Because Suboxone seems to be very popular, obviously. Is that because it may be the cheapest?
I think it's the cheapest.
And that's just a guess.
They say methadone and buprenorphine are like the gold standard.
Yeah, I'm not holding you to that. I just thought that was kind of in relationship to what you just asked. Now, Russ, from some of the ways that she mentioned outside of the injection, how do you think inmates can find a way to bring what's being given to them back to the population, or maybe just to stockpile it?
Well, the first thing is you should never underestimate an inmate's ability to misdirect someone and to be able to pocket or get it out of their mouth or do something. We had one particular inmate that what he could do is he could put a piece of cellophane up above on his soft palate so that you couldn't see it if you looked in his mouth, and he could transfer pills and other things up onto that cellophane and actually spin it around and wrap it up in a way that no one could ever see it. And he actually demonstrated this for us. So I'm sure he passed that on to other people. I'm sure that other inmates have figured that out on their own. It's a matter of being cognizant of what's happening and not letting them misdirect you. And that's why, as much as custody sometimes doesn't want to be involved in this, we got to remember that, looking in their mouth and trying to detect them doing something is a custodial function, because that's a search, and if they're doing something wrong, then it can become a seizure. And, for the most part, nursing staff and stuff aren't equipped to deal with an inmate who's obviously involved in that kind of trafficking. And I think you also have to be cognizant of the fact that, inmates are, by their nature, very predatory. And so, the fact that an inmate could get a hold of Suboxone and keep it out there, and maybe there's a desperate inmate that up to this point has been hitting on a good heroin source. I'm sure there's some inmates out there willing to sell him some Suboxone to let him, come down off of that. And, desperate customers are great for these inmates. They are very, very predatory. So you have to think about what the whole picture is of that with regard to, how that might fit into a black market scenario.
Well, actually, you touched on one of our concerns. Actually, there's two concerns you actually touched on right now. One concern is the threat that MATs can actually pose to the facility in regards to inmates that are on Suboxone now being threatened to go to the line and find some way to bring that back. I know there are some inmates that actually manage to hold it in their mouth, liquid form or whatever it is, and unfortunately they're not being properly checked. They go back to their housing and they spit on paper and they sell the strips because I guess it just soaks in. And that's something that obviously there has to be that partnership between custody and medical. But you want to hear something funny, guys? I see a little resistance from custody. Not everybody, but there is some custody that don't feel that they should be responsible for checking the inmates to make sure they're taking the MATs. They feel a lot of that responsibility should fall on medical. And I'm saying, well, I disagree with that. And I'll say it out now. It's just a regular dialogue, just my opinion. But the reason why I disagree with custody that's saying that is you're the fail-safe. I'm not leaving medical out of it. Medical's part of that responsibility, and we'll explain a procedure with Suboxone, with holding it in the mouth and being observed by medical. But I definitely feel that final touch should also come from custody when you're checking the mouth and just maybe making sure that you eliminate as much as you can any possibility that they can take it back to the unit. So Connie, let's talk about the Suboxone strips and the process that you find is the best way that limits the inmate from taking it back to the unit, his housing area.
I mean, right now, I know that we typically, they have to stay with us for the entire time that it takes for it to be dissolved. And then we make sure that they're drinking multiple cups of water. When they come to the med line, they have to come to the med line with 2 cups of water. And we provide a cup of water at the med line. And before they leave the waiting area, after they've had it dissolved, we actually have the custody officer who will do another check to make sure that the med is no longer in their mouth. So it isn't a one-shot nurse checks and then you just go along your way. It is both nursing and custody who make sure that med is gone.
And what's a good amount of time? Let's say for Suboxone, I'm hearing 7 minutes is good.
So usually they sit for about 10.
10.
Yeah.
And let me ask a question. Is it a good idea also for, let's say the officer has a follow-up to tell the inmate, do me a favor, drink this small glass of water, swish it around your mouth a little bit, and deep swallow?
Yeah, there's nothing wrong with that.
Yeah, because I know that's kind of like a follow-up. I know even some cases when inmates are on narcotics, they also like to smash the narcotic down. And why? There's a face with that. What happened with that? I study body language.
There's
What was
tons
that?
of stuff that we've been trying to go through to make sure that they're unable to crush their own meds. So even from an administration perspective, you know, we looked at crushing meds versus not crushing meds. Are they more likely to pass meds if they're crushed versus not? You know, I mean, where there's a will, there's a way. Whether we crush them or don't crush them, they crush them or not crush them, there's always been like this way that they've been able to swindle and get the meds out. I mean, but I think it's the due diligence of everybody in that med line that really makes it very tough for them to get those meds back to the housing unit.
Right. And Russ, as you mentioned, you are in agreement with the partnership between custody and medical, making sure that the inmate doesn't, as best they can, doesn't leave the med line with anything they shouldn't have.
Oh, absolutely. And I do understand where staff sometimes feel like they don't want to be involved in that because, you know, it's a really time intensive thing. And when you're trying to get all of your other stuff done, I think sometimes staff sees that as a drag on their day because there's that much less time for them to do the other things that they're supposed to do. But it's a necessary function. It's something that we have to do because that's part of our special skill set is to be able to detect those things that the inmates are trying to get by. Obviously, we should be much better at detecting that. We should be much more on top of what an inmate's doing with his hands, how he's looking around, and you know, studying that body language and behavior so that we can, you know, stop you know, disasters from happening.
Yeah, and Connie, let me ask you a question. Just going through my notes here. What's how many are actually, like, percentage-wise, the population of inmates that are on Suboxone? Because Russ mentioned the time. You know, do we have enough to have each inmate sit down for 7 to 10 minutes? Is the population great that takes MATs, or is it not as high as people like to think it is?
So it's not as high as people like to think there is. I mean, on average, I recall us having anywhere from 25 to maybe 35 people at a time on MAT.
Out of how many though? Like,
so the population size was about 1,300, and so there wasn't like a huge amount on MAT at a time. But I mean, the population is growing. The prison population in general is growing, and you know, that number could go up. I mean, as we've already said, like, opioid addiction is an epidemic in the United States. And so I can only imagine what that looks like in the prison right now.
But that is something that actually we're trying to control. I think that more of the process right now should be focused on, if we're going to give the inmates the MATs, it's not just about starting them, it's about finishing them. And I think that we should definitely get involved in trying to give them an end date, you know, because obviously some of these inmates are going to be going back to the streets. And just for safety and security concerns, as we're discussing the balance between medical and the custody staff to kind of make sure that the medication stays where it's supposed to stay and it's not being misused, is there a HIPAA violation there in regards to custody now knowing what the inmates are taking?
Well, I mean, I think there's some things. So the expectation is that you make best efforts to respect the inmate's privacy, and the facility doesn't necessarily give us, I guess, the way you respect someone's privacy in a hospital setting versus depending on where your med line is set up. So because MAT is typically the same time every day, so say it's at 2 p.m., everybody knows that 2 p.m. call is for MAT. Nursing doesn't have to, or medical doesn't have to say, oh, here are all the MAT inmates. We just know that 2 o'clock is MAT medline, and that's who's lining up right now. So I think if you don't have someone who's openly saying, oh yeah, here are all the people who get methadone, or here are all the people who get Suboxone, because you have the same people for MAT on the same line, but not necessarily getting the same med or the same dosage. So there's a way that you're still respecting their HIPAA, because you're not making some grand announcement, but the 2 o'clock med line is MAT, and most people know that. If the nurse was actually having like a counseling session about the meds or about signs and symptoms in a public space, then that would be a violation of the inmate's HIPAA rights. But that's not what's happening at Medline. You're coming on the line, you're getting your med, you're sitting for however long you got to sit, and then you're out the door. The moment it turns to some sort of medication counseling session, even if it's just for a few minutes, if the officer is standing at the window and is in earshot or can hear that conversation, then there might be some concern as to whether or not there's a violation. But other than that, you coming to get your meds and you going on about your way is not a violation.
Right. And again, the officer is just concerned about the procedure, right, making sure that the inmates are ingesting it. I would like to think at some level, safety and security, I don't want to say this is 100%, but safety and security can supersede HIPAA, right? At some points?
So yes, at some points there are where that does happen. I mean, if there's a medical emergency and custody is in the room when it happens, whatever information is exchanged at that time, like we can't, if we got to stabilize someone, we can't say, oh, custody's in the room, we can't talk about it. You know, like there are times where you just have to say whatever you have to say, especially when you know you're in one of those situations where you're trying to get a patient stable, or, you know, there is some emergent situation that you're trying to address.
Right, and I noticed that also touches also with PREA, and when transgenders openly admit, let's say they're transgender, to mental health. Mental health may have to now tell the facility, because there has to be efforts to protect that vulnerable population, or what would be considered a more vulnerable population. So I do think that there are some times where safety and security, as long as it's justified, specifically justified, can supersede HIPAA. But again, administration better be aware of that, you know, absolutely, because we want to make sure we don't violate HIPAA in the process. Now, this is where I'm going to go to Russ first and then back to you, Connie. Then we can kind of finish up this interview. But I think this was very informative. And I think we're actually going to have to do this again, because I want to touch on juveniles dealing with medication-assisted treatment, because I know there may be a different process. I know you said you may want to research that a little bit. And yes, Russ actually may be a little familiar because he's seen it practice when he worked with the juveniles out in California. From your custody perspective, Russ, do you feel that medication-assisted treatment has the potential to violate the safety and security of a correctional facility, jail, prison, etc.?
Well, it does, obviously, to a point, but let me just back up from that a little bit and just say that, you know, corrections is a risk business, and everything that we do day in and day out, we're managing certain risks. Just by letting the inmate population out onto the yard every day, that's a risk. You know, by sending them to the chow hall every day, that's a risk too. But these are things that we manage, and the way that we manage these things is that, you know, we have you know, our physical controls and barriers and weaponry and trained staff and all kinds of policies and procedures and emergency policies and procedures and all of that. So, you know, ultimately what we have here is we have another risk, but it's a risk that's manageable. And it's not something that's so far beyond the pale that we have to, you know, look at it and gawk at it and say, oh my gosh, every time. It's just something that we, you know, we have to look at what our physical situation is for passing out meds. We have to decide what a good policy is. We need to be on board with whatever, you know, get with medical and figure out with them, write a good policy, write a good procedure, and then, you know, get input from the two sides of the different staff and make it work. Because like I say, every day, all day long, that's all we do is manage risks.
Let me ask a question just so we can balance your answer out, Russ, because I agree with you 100%. What would be your perspective if we didn't do it, though? what would be your safety concerns if we stop this practice right now? Would you have any safety concerns?
I think that the concerns that I would have would be you'd be putting a specific part of the population in a position where they might be really desperate. They might have to act out. They might want to hurt themselves in ways to be able to get some opiates, into their system. So I think that those are things that we would have to look at that would be on the negative side. The treatment, it seems to work for them. It seems to keep them placated to a degree. So I think I'd be much more in favor of, a placated population than a population that's out there doing risky things, seeking drugs and different things, and try and find ways to make that work.
And this actually invites comments right now, guys. If you're interested, comment on where you feel the greater risk is, giving the population or not giving it. I think Russ, from a custody perspective, provided a very good balanced answer in regards to the risk that we know we have to take. And then obviously if we didn't do it, again, the withdrawal, the inmates being more impulsive. And we also mentioned earlier in the show, just being around bodily fluids, like diarrhea, vomit, whatever the symptoms would produce. Now, Connie, your perspective, do you like this practice? Do you feel it's needed? What are your concerns in regards to safety and security? And kind of give me, I'm looking for like a balanced answer like Russ gave, like if we did do it and if we didn't do it.
So I think on one end, there is that concern that it's just not suitable for the environment. But I think on the other end, the reality is that we have an addicted population that comes in. They are a high-risk population. They will do anything to get that high, right? Whether it means that they learn how to ingest hand sanitizer or they start crushing basic things that they get from commissary trying to get high, then we start dealing with these unknown codes. We don't know how to stabilize because we don't know what they've ingested. I think that from the perspective of you having a population who are just unpredictable, at least when they are on MAT that they are stable or as stable as we can get them. And they're a little bit more predictable to deal with, which I think makes for a safer facility for everyone.
If I may, Connie, you actually mentioned a very good point in regards to medical perspective. If they are getting high, at least you know what they're getting high on and you know how to treat them, as opposed to them finding some form of K2 or something, which is very hard to treat because you don't know what they're taking. Exactly. I never thought about that from a medical perspective. I think that was very informative. But again, I didn't mean to cut you off. I thought that was a very good, what you just mentioned.
Yeah, no, I mean, I think for us, it really is, it's almost that statement they say, you stick with the animal you can kind of deal with. It's one of those things where it's like, okay, we know that here are some of the things that they come in with. We know we've got policies and procedures to deal with these things, and we know how to stabilize. Now you have an inmate who's kind of rogue out there, who's seeking, and like he's willing to do anything and everything to get this high that he's looking for. So for me, I think the MAT keeps the facility safe. I think it keeps the inmate safe. And I think it keeps us all safer just because it's happening. I mean, I think it's more of having to deal with our own personal feelings and our own personal biases about addiction and about inmates. I get it. Many of these inmates have done things to hurt people that we've worked with. And so there's some strong feelings about what we think inmates should and shouldn't get. And I think when we deny that we have those feelings, that we're doing ourselves a disservice. We shouldn't deny the fact that we have issues with addiction, right? Like there's some people feel like, oh, just stop already, or look at how you've already destroyed your family. At what point do you stop because of how your addiction has taken over your life? And I think because we may not understand the cycle of addiction and how much of an impact, how much it takes over their lives, we may have a little bias about us now being the bearers of this treatment because it's tax dollars that are paying for this treatment. I mean, we can't get past that. I mean, all of it is tax dollars, quite frankly, but how do we make sure that we keep everybody safe? And I think MAT is a way that we actually keep the inmate safe, we keep the facility safe, and we keep ourselves safe, because you don't have unstable inmates running around. You're not responding to these codes that you don't know what you're responding to. You're not putting yourselves or the staff in positions to have to deal with something that could be avoided.
Right now, before we get to closing, I got one more question for you, Connie. What advice would you give to medical? I know we touched on this a little bit, but now just kind of in closing, and since obviously we're going to have these MATs in our facility, where do we need to go with this? How do we make this better in regards to trying to get a begin and end date? Because I think that would be a big thing for us. I think that if we could know that this person has a scheduled route of treatment, and we know at one time this is when we're going to start trying to wean them off, I think that could alleviate a lot of our concerns. I think a big part of our concerns is that we think that this supply of MATs is infinite. So what is it that that I guess the profession can do itself to kind of start looking for that end date?
So, I mean, the prescriber is going to do what's clinically appropriate for whatever that patient has presented. And so if the patient has a long history of substance abuse, he may not be able to start tapering right away. He may have to maintain this person for some time and then taper. But there are best practices that the prescriber should be aware of. And I think that's a conversation that needs to happen between medical and custody. So here is the guideline, almost like a matrix. If someone has X amount of, time that they've been using or abusing drugs, this is generally how long it takes for this person to be stabilized, and generally how long it takes for us to taper. I think that kind of communication could help dispel some of they're going to be treated forever, right? But I think there is that space where medical feels like, well, we shouldn't have to tell them what we're prescribing or how we're prescribing. But I think when it's something as sensitive as MAT, and it's about raising awareness and educating, that medical does need to step out the box and say, so here's our population, here's what the prescribing practice is. I know that NCCHC has all these guidelines about MAT and how you're supposed to, what the standard of care is for anyone who's inducted into the MAT program. I know that different states have some regulations on like narcotics and how they should be managed and where they should be held at and stored at and under what lock and what key and who has the keys. So there's so many moving parts, I think, to MAT that there has to be a very definitive conversation about what the meds are, where they're going to be stored, how many are we looking to treat, what that time frame is like, and in general, that information could be shared. If we start going into specific treatment plans for each inmate, I think that's where medical would feel uneasy.
Right, and again, I got one more question for you before we go to a close. Do MATs have addictive properties?
Yes, there could be some. They say that they're supposed to suppress the craving, but it's still a synthetic opioid. And so while there is that suppression and you don't have that same craving and it doesn't give you the high, there's a reason why they want it, right? So, I mean, sometimes you think of like the placebo effect. Are you just giving them something and they think it works, so it works? Or in this case, you're giving them, an actual synthetic opioid to help sort of, suppress a little bit what the real thing would be giving them. So, I mean, I don't know all the science behind it and how exactly it works, but I do know that, it is a synthetic opioid. And so there are still some of those elements that you would see present based on, what you'd see with the actual thing.
Right. So the concern would be, and again, we don't have to elaborate anymore, but I guess the concern would be, are we trading addictions? And I'm hopefully that's why I think, but I do agree with what you're saying, is that as long as we focus on whatever that formula is and try to get them to an end game, you are slowing down one addiction safely and then eventually getting them off. It's like someone taking a nicotine patch. if you will, in my opinion. I don't mean to be crude with the metaphor or simplistic, but I kind of feel it's a lesser or a greater form of that. Now, again, we're going to go to close. So, Russ, any final tips that you would give in regards to custody dealing with MATs?
Yeah, the final thing that I think that that I want to say about this is we've explored the angle from what we see on the medical side and stuff. There is a whole other angle with regard to what a lot of different facilities are experiencing with an actual black market in that substance. So I didn't want anyone to get confused as to what we were talking about, because there is a whole other black market with regard to Suboxone and some of those other things coming in. We're right now only talking about the treatment side and the prevention from being able to keep inmates from exploiting that part of the distribution process.
And I think it was great that we had this dialogue, because it gives an understanding of why it may be needed, but also kind of elaborate medical's position on it and try to see where we can meet in the middle. And maybe in the near future, we can get some guests on and we could touch on that black market side of things. But I really think this was a great way to start the dialogue, just to get an understanding, because maybe more people will watch this now and say, you know what, I was 100% against it, but now I'm about 60%. You know, because nothing's ever, listen, this is corrections. You're never going to be 100% either way, but at least this kind of starts bringing the dialogue into the middle. And once you get close to the middle, you start seeing the other perspective. You can't always stay on the right or the left, because you're not going to see the other perspective. The perspective goes when you start going into the middle. And I appreciate dialogue like this, because along with that understanding, it brings about respect. And that's the key. We can't fight for recognition in this profession if we don't get along behind that wall. What we don't realize is the greatest recognition we could ever get is literally from the people that work around us, because they know our jobs the most. Now, Connie, just in closing, what advice would you give to your medical peers or custody in regards to safety and security and just the overall MAT movement?
I mean, I think just communication. I think communication and transparency, there's got to be just trust that, you know, we're going to try to do the right thing. We understand the security concerns. We understand, you know, logistically how it can be very difficult in some facilities to actually have MAT happen. And so I think there's a flexibility that medical will need to have in order to work with custody to actually make it happen. At the end of the day, I think we all want to go home safely. If we can avoid some certain codes, I think we should need to make best efforts to do that. And I mean, there's going to always be tons of bureaucracy anytime something new is introduced. And I think taking away that fear of the unknown, educating everyone about what MAT really is, what impact it will have on the inmates, and that knowing that medical will be diligent in the event that there is an inmate who's identified as being abusive of it, right? Like, because then that communication has to come back to medical to say, hey, listen, this guy has done X, Y, or Z with the methadone or with the Suboxone. Can you guys take him off? You know, there's got to be some communication both ways in order for us to make sure that we're both doing the right thing.
I love that. And guys, if you notice, outside the MAT discussion, there is an underlying tone here, and it's communication and partnership. You know, instead of us being isolated and trying to get the mission done, it makes sense to work together. And again, I'm going to touch a little bit on what Connie said in agreement with Russ. These are new things, and obviously if it's something that's being implemented, we can't be resistant to it. You know, we could try to deal with it before it gets implemented. Hopefully we get our voices heard and people listen. But at one point, if no one's listening, and it sucks because it happens in our profession, that's why we have shows like this, because you never know who's going to watch this, guys. But until that point, when we get people that are willing to listen to our side, it's sad to say, but we may be forced into predicaments where we have to make it work for our own safety. We don't want to be resistant to making it work, because then we're going to leave ourselves vulnerable. But again, that's the initial step. Right now, we're at the point where we're doing shows like this so someone can listen, and then maybe they can go back and say, hey, maybe we can make this better. But in the meantime, until we get to that point, if we're resistant and things are being implemented and we're just letting it run around, that's going to hurt us eventually. And that's not good for any of us. So I thought this was a great dialogue, a needed discussion. Next time we'll touch on I believe juvenile medication-assisted treatment I want to touch on next. I know you guys want to research that a little bit. And maybe, Russ, if you could do a little shopping, we got a great website, a great Facebook page called Keepers of Chaos. Maybe you can get someone that would like to talk about the black market in regards to medication-assisted treatment like the Suboxone and Withdrawal, stuff like that. And then, as always, guys, it's a pleasure. Just one last shout-out for both parties, guys. Don't forget, check out Russ's Facebook page, Keepers of Chaos. He's over 1,000 pages, growing. Very good dialogue. Just stuff that's really making an effort to move this profession forward. And there's a goal for this, guys. This is not going to be just a page that stays on Facebook. This is going to be a page that's going to start traveling out because Russ is retired. Russ is making money. And Russ is hoping to get some conferences going. You know, but it's what we need. So, and another shout out again to Connie, Alleyne. I'm going to give a shout out to the Civilians Corrections Academy. This is something that we need in the field because obviously the more that people are trained, the more safer our facilities could be. And this is through her experience. You hear the dialogue she's having. She knows her stuff. And let me tell you real quick before we go, you know what defines an expert? I found this out. But really what defines an expert is someone that's humble enough to know they don't know, but they know where to get the resources. Yeah. And that's what we're here for. We know we don't know everything, but we sure as hell know where to get our resources. And that's what makes us somewhat of experts. If you go. But as always, guys, the show is Tear Talk. Love you guys. Stay safe if you haven't. Please subscribe, interact, engage, comment, hit that bell. That bell's going to notify you every time I post a video. Stay safe, guys.